just start now. All right, awesome. So, Laura, why don't you just introduce yourself to begin with? Just say, what you're doing at the moment, what's your job, and then we can go from there.
Yeah, great. So I'm Laura Lalinek. I'm a sport and exercise physician based in Melbourne. I work in private practice, so in a clinic, in a sports medicine clinic, as well as being the Chief Medical Officer at Netball Australia and for AFLW. And I'm also the Diamond, so the Netball Australia touring doctor as well.
Unreal, unreal. It sounds like you've got a lot on your plate. What sort of like a week in your life like sort of look like at the moment? I mean, imagine you're juggling a few different jobs there, so it'd be pretty hectic, but pretty enjoyable as well, hey?
Yeah, definitely. I like the variety, so it doesn't worry me jumping between jobs, like 2 days a week being like Monday and Thursday I'm at AFL House doing AFLW stuff. Tuesday, Friday I'm doing netball from home. And then Wednesday I'm in private practice, and we often have quite a few extracurricular stuff we do, like sitting on boards like the Sports Medicine Australia board or organising the annual Sports Medicine Conference at the moment. So there's a few evening meetings as well. And then obviously when you're on tour, such as with the Diamonds, they're generally 3 or 4 week tours, either internationally or sort of Australia, New Zealand. So then you're sort of full-time in that environment, but often doing then your other jobs when you can on the side, often in the evening. So it's very varied. I don't think I could ever go back to a Monday to Friday sort of role where you're in the same office every day. I quite like my variety, and I like a bit from home, bit in the office, bit on tour. It makes it really interesting, and you never sort of get bored, that's for sure.
I think that's the thing. Hey, like you find when most people like specialize in a certain area, they are not just tied to one thing. They are like have their fingers in a few different pots, and just to keep them interested, whether it's in research or like maybe it's some educational leadership thing, or doing different things as your role suggests. So it's kind of cool to see that you can actually not be like just segmented in like one area. You can just sort of branch out, which is nice.
Yeah, and I think that's the beauty of medicine. I mean, I don't think people probably tell you too much when you're a medical student that might, you could do anything. And as you say, like you might be a hospital doctor, but you're also doing your PhD, or you're doing some research, or you're sitting on a university doing some tutoring. Like, that's what the beauty of medicine is. It's so diverse, and you can do so many different things in your day.
Exactly. Do you miss the hospital at all?
Definitely. Like I used to love emergency and the busyness of that, and the unknown. There's no predictability about what's coming in, and your day just flies by. I actually really enjoyed nights as well. That never worried me. So no, definitely I do. There's times when I think, and certainly during COVID when things changed dramatically, we'd sort of teed up potentially with one of the hospitals to come back in sort of fast track and do some MSK stuff there. That excited me. And then, football AFL hubs happened, and that sort of got pushed to the side. But yeah, I do definitely. But I must say the lifestyle that working for yourself as a sports medicine doctor brings is hard to beat, I think.
Yeah, it's not something that we get exposed to a lot. I think I know of maybe one person in the hospital that I used to work at in the year above me who is sort of heading in that sports medicine direction. But do you want to just like walk us through how you actually get there? Because apart from seeing the doctors on TV for like AFL sports teams or whatever, you don't actually. Well, I don't know. From my point of view, I don't get exposed to them.
No, definitely not. And, you receive so little training in medical school. You might get a month of MSK and how to examine a knee, and you never really get beyond that. For me, it was mainly working. I sort of thought I'd go into emergency when I finished med school. I went into orthopedics first on a rotation in my internship, and I was in Darwin. So it was very much younger population coming in, as opposed to lots of sort of neck of femur fractures. Was far more traumatic fractures and things. So it was really sort of sports medicine, but at the more orthopedic end. So I got exposed to that first, and I thought, oh gosh, I really enjoy this musculoskeletal side of things. I enjoyed the operating, but I knew I would never be a surgeon. I didn't have that sort of risk-taking behaviour in me. I could never handle that amount of responsibility. And then I sort of did a bit of rehab medicine, which again is a lot of neuro, which is quite interesting, and then a lot of emergency. And I sort of talked to one of the rehab registrars at the time, and she mentioned this training program for sport and exercise physicians. And when I thought about it, it sort of put all those elements together. It's got a little bit of medicine, a little heaps of MSK, obviously, fair bit of pain medicine, which is important for people to know before they get into it. There's a lot of pain management, chronic pain, and then emergency, obviously, when you're working in collision sports or even things like netball, you get here and there, you get trauma. So really my process was, obviously doing your internship, doing your years of residency, which were required, and then sitting the entry exam. I think it was in my second year of residency, successfully getting that, and then sitting an interview to get onto the sports medicine program. And then the training program sort of how many, minimum 4 years, but, most people take about 5. And then you become a consultant. There's obviously an exit exam, lots of sort of hurdles to jump through in terms of covering different sports. You have to cover over 10 sports. You have to spend a year with the team, which all of us do anyway, because that's why we're doing this. You've got to travel internationally with the team within that training program. So there's a lot of on-the-job experience. Certainly now it's getting harder and harder to get into because people are starting to realise it's a great specialty. So you've got to have done stuff a bit like any training in the hospital. You really have to do those unaccredited registrar years. So when you're a resident in the hospital, often covering teams, it might be more at the state league level than the high professional level, and getting a feel for, sitting in with consultants, doing that footy coverage or netball coverage or whatever you want it to be, and then applying for the training program. And that gets you extra points on your CV and your application.
Got you. And is it like I had a brief look at there's this website that has all the specialties that you can get into and stuff. Is it PGY 4 is the earliest that you can get into, or you can get into it earlier?
No, you're right. That's the early. You've got to do your 2 residency years um, to tick off, and you've got to do certain rotations in there. You've got to do orthopedics. You've got to do emergency. Ideally, if you can, harder to get, but cardiology, rheumatology, rehab, I think was really good for your neuro exam experience. So yeah, you've got to do certain rotations, and you've got to do that 3 years before you enter the program. And to be honest, really because like a lot of specialties, you're like a lot of especially in the hospital and you've got a bit more supervision. Once you're in sports med, you're in a clinic room with the patient. There's not a lot of shadowing. You've got consultants around and registrars around to ask, but they're all in private consulting as well. So you're sort of thrown in the deep end quite quickly with paying patients. It's all private at the moment. So you really need to have some experience managing patients before you go into it.
Yeah, it sounds like almost GP like in the sense that in order to get the most experience, you just get a patient in the room, you take a history, do an exam, think about what investigations you want to order and go from there. There's not much like you can't have the GP sitting in for every consultation. They've got their own patients to see.
That's right. And you'll always get help, but you're running to a schedule as well. So you can't wait for that consultant to finish with their patient to get that help. And probably as a result, you're ordering a fair few extra investigations that maybe the more senior guys don't, and that's okay. And certainly at the beginning, you do a lot of bulk billing because you sort of feel like you don't really know. You're not quite across what's going on. But, after everyone, you talk to your consultant at the end of the day, you go through all the cases. And certainly, most clinics now do a month or so of shadowing. So when you're just sitting in and just observing.
Yeah, I was chatting to a GP registrar a few weeks ago, and she was saying the same sort of thing that you don't feel like you are offering much value early on because you're so junior, and you're like, well, I don't feel like I should charge this person X amount, and you just end up bulk billing them. It's it takes a while, I guess, to learn that your time is valuable and that you can actually charge a certain price for your skills.
Oh, definitely. And that is a trap to fall into for sure. And you've got to get out of it relatively quickly because you realize these people are, getting your expertise, but not just yours, but your consultant or senior registrars as they give you input as well.
Yeah, yeah. I think, like when you were saying, like, of course, every specialty, the bottleneck just tightens, and the more they realize that this is actually a cool thing to get into, the more stuff you have to do to try to put yourself in the best position. When you were saying like being like an unaccredited registrar and like sports med, like how does that? I don't know if you've seen it work or if there's currently positions that do that. Like, but how do you combine that with hospital medicine, or is it something you just have to do on the weekends whilst you already have a full-time contract with a hospital? Like, I feel like that'd be pretty tricky.
It is. It's really hard. And it's definitely not a formal unaccredited registrar. You're definitely a junior doctor in the hospital full time, or you're beyond your first 2 years and you're locuming. A lot of people do that now. So they'll locum and then do the sports coverage on the side. But what I did, certainly, I was in the hospital doing surgical rotations, and then I'd go to the game on the weekend. I get cover if I couldn't. I was working at the VFL level, so the state league level of footy. And then you'd go to trainings after work. You just quickly get in the car as soon as you could, drive there. So it's definitely a lot of after hours. But you learn so much doing that, because you learn from the physios when you're at that level, definitely. Like, they're the ones they're just expert musculoskeletal, people, really. They have all that training behind them. That's all they do for 4 years. So you go into the club and essentially you learn off them, learn off their exams. You see injuries, you're just sort of managing it. Try and get a mentor so you can give them a call if something pops up you're not sure about. But essentially, you're full-time hospital and then covering games and trainings in the evenings and the weekend.
It sort of sounds like a lot of these like high-end surgical specialty programs where it's like, yeah, you do your full-time job and then on the weekends you're doing all this research, you're trying to do courses, you're just trying to like tick off all the boxes to put yourself in the best position.
That's exactly, and it is really hard. I mean, I loved those days because I was super enthusiastic. Like, I think I'd struggle to do it now, but I was very enthusiastic and I learnt so much. And there's low expectations. They know you're coming from the hospital. You're not a sports medicine trainee yet. They get it, but they're just grateful often at that level to have a doctor around that can help them when things pop up, even GP sort of things.
It sounds like I'm back at footy training hearing about that schedule. I'm just like, oh, I'm so glad I quit. But um, how did you get in touch with like people to organize this sort of like quote unquote unaccredited role where you just putting your own time out there?
Yeah, it was interesting actually. I actually went onto the Sportsmed Australia job board. So I think it's a free access one, and you go on there, and they actually had a volunteer doctor role at Spotswood, which is the sort of not state league level, I guess 1 or 2 below, you might know. And so I just went to games there, and I wasn't paid, but I picked up a bit of knowledge. I literally went to maybe 10 games that season, put a finger in, managed a nose fracture, like just simple stuff that, particularly in the hospitals, you're sort of quite versed on trauma because you're doing a fair bit of emergency and stuff. So that's where it started, and then I actually got headhunted from there, where a VFL club, Williamstown VFL, contacted me and said, "Oh, would you like a paid role and to step up into state league?" So it just sort of went from there. Certainly now, because of AFLW coming in, VFLW, and same in the interstate realms, there is a lot of roles at that state league level. I'm talking footy, but none of that. The netball state league clubs have doctors, so there's heaps of opportunity there. Sports Medicine Australia is a good place to start, as well as our college, so the Australasian College of Sport and Exercise Medicine. Doesn't have so much of a job board, but they often advertise in their newsletter, if you can join that, jobs that are popping up. So it's just having a really good look. If you know a sports med reg or doctor, just put your hand up and say you're interested, because there'll always be cover coming up as well.
Yeah. Yeah, that's cool. And I guess like just like cold call to someone or like a sports organization that you're, support or you're interested in, right? I'll put everything in that description so people can like, check out, where to go. But yeah, definitely need to sort it out yourself and put yourself out there, I think is the best thing, hey?
Definitely. And I would say there's obviously restrictions. Like, as an intern, I don't think you have the capacity to do this legally. Once you're a resident, you can. You just obviously call your indemnity provider, make sure you're covered, because that's I've never had an issue. I've always been, but just make sure that is the case. And just, when you organise scans and stuff, you can do that. You need to get a provider number for that location. You can organise scans as if it's essentially a GP for billing. So whatever GP rebates people get for their scans, that's what they will get. And then you can get some blank script pads or to that club, if you get a provider number at that club, which you should do technically. You can get some script pads ordered from Medicare. So you can sort of set yourself up in a little mini clinic. But I would just stress, check your insurance, but also have a mentor in sports med, so you don't get yourself into a situation where you're handling something that's a bit out of your depth.
Yeah. No, that's definitely a great point because I mean, you don't even think about it. Like you're going into like the private practice. This isn't like a public sector thing. So when we're operating at the hospital at intern or resident level, like you're under the veil of the public health system, which is completely different to private land. What's that exam that you guys had to sit to get into the sports medicine? Like you said that you sat it in your in PGY2, right? So how was that, and how did you like prepare for it, and what does it sort of entail?
Yeah. It's really a heavy duty MSK anatomy, a fair bit of physiology. I would say it's sort of final year, all medical student level, but like in depth, going back to that, I guess, because you sort of lose a little bit of that knowledge. Certainly, the anatomy to the depth that you need to know for MSK was a lot of it was new to me. Like I don't think I got to that extent in medical school, definitely not. Um, and then the other components, it's a good question. It was anatomy, physiology. Oh gosh, I'll come back. I'll let you know. I'll have to have a look. Another component to it, but essentially, it's books, rote learning. There's recommended textbooks, and it's a fair bit of study. I did a lot of that study whilst I was on. I was sort of lucky. I was on that surgical rotation, but not. I was in like a combination of ENT and Max Fax, and the numbers were quite low in the hospital. So there was times afternoons where I had done everything and I had a few hours off, and I just went to the sort of common room and just studied for a few hours and just waited to see if I got any calls. So I sort of had that opportunity. So it worked in really well for me. But if you were really busy on the wards or on your rotation, you'd have to go into the evenings and weekends as well. But I did spend quite a few weekends in the library, rote learning musculoskeletal anatomy. Mm.
I think it's the same with like everything. Like you just gotta put in that after hours for these sort of prerequisite application things that you need to get sorted.
The nice thing is you learn something that helps you. Like, as soon as you're on the program, you're like, oh, I understand why we learned all that anatomy because now I've got to interpret this MRI and understand what the rotator cuff is. So, like, it's useful, which is so nice compared to, I feel it, medical school, you learn so much and half of it you'll never use because you'll never go into that specialty. So it's so nice going into sort of honing down into a specialist area.
100%. You see the relevance almost immediately when you see that patient and they have that scan with that finding, and you treat that condition that you learnt about in that lecture. So yeah. So apart from doing an internship, doing at least 2 years as a resi, and then minimum PGY4, passing this sports med exam, is there anything else that you need to do before you sort of think about getting into sports med, or is there any other prerequisites?
I definitely sit in with registrars or consultants. Most clinics will have, ability for you to do that. The bigger clinics definitely. And I think that's important from your end because you need to understand it seems, flashy and cool when you're sidelined dealing with high-end athletes, but that's such a small part of the role. I mean, obviously it's a big part if you're working with a team, but a lot of sports doctors will be working in clinic a lot. And as you become a consultant, you see less and less acute stuff. So registrar, you get to see all the ACLs, the acute fractures and things like that. Once you're a consultant, you've got wait lists of 6 weeks to sort of 3 months, and you're starting to see chronic issues, and you're starting to see issues that other people haven't had any success with. And I think, I'm potentially a little bit biased because I think as a female, I see a lot of it, but I see a lot of chronic pain. So a lot of back pain, neck pain, a lot of maybe, persistent pain that's been misdiagnosed as structural pathology in the past. And a patient's been heavily worked up, investigated, injected, but nothing changes their pain, and it's because they've actually got persistent pain in itself, which I really enjoy that. But I think coming into it, you sort of need to understand what you will be seeing because it's not everyone's cup of tea to see those sort of patients, those chronically in pain patients that have had years and years of issues. So I think that's the first part of sitting in. And then the second part is that you definitely get points in your application for it because people, the college wants to see that you really understand what the role's about.
You get points for actually having experience, or is it just what's that for?
Sitting in. Yeah. Then they realize, you are invested, but you also are understanding of what it is. It's not just about the elite side of things. And in saying that, it's a bit tricky coming into elite environments like footy trainings or things like that, but always there's no harm in asking. And it might just be a day of shadowing to understand, like, and that stuff's fun, and that will always be the most interesting side of sports med for a lot of us. The other things is rural and regional applicants, like many specialties, get extra advantage in their application, as do females. So that it's another college that's really on the lookout to even up numbers. So you will get an extra point on your application if you're female.
Did you feel like outnumbered, or like were there like a lot of like male applicants, when you got on to the program, or has it changed much like since you got on?
I think it's changing. I was definitely one of two females in my year that got on, and I think there was 12 to 15 maybe nationally that got on. So I was definitely on the lower end, and definitely still, for a while in my clinic, I was the only female consultant, but it's definitely changing. There's a lot of registrars now coming through, which is great because of probably, making it, giving extra points in the application is a great way to get females to apply, but also to get them to that interview stage. Um, so it's definitely evening out. At the elite male sport end, it's still really behind. I think I was one of the first females to be an AFL head doctor. But now, look, I've left end of last year, but there's one that's sort of come in. So 1 in 18. So we're getting there, but definitely that it's like many specialties, certainly nothing like orthopedics or anything like that, but it's definitely a little bit skewed towards male applicants. And I think that's just historically been because male doctors see, they have an interest in the area.
Yeah, I feel like, even through school, it's just like you're a guy, you play sport. That's the easy way to, get friends. That's the easy way to fit in with everyone. Like it's just a natural like inclination for a lot of like males. But no, it's good I feel like there's just been like such a rise in like female sport. So hopefully that pushes people into that direction, like with AFLW, with all like the Matildas and everything. I mean, obviously they've been around for a while, but like, I feel like it's just been like a massive like switch or like surge from like the whole country's point of view towards that. So,
Definitely. It's getting far more media, which is fantastic.
and then it gets like the other sports that probably didn't have as much traction, and then they're getting like that's getting a push, and then there's female component of that sport which is getting a push as well. So yeah, hopefully it sort of changes and like levels out in the future as well.
I think so. And this year at Paris Olympics, we've got the first ever female head of medical for the Australian team, Dr. Caroline Broderick, who's very well known in the sports medicine field, and that's just huge. What a fantastic achievement, and yeah, so it's changing.
100%. That's awesome to hear. Take us back to like how you got into this whole like medical thing, this becoming a doctor. Like, what was your sort of pathway in? Were you like cookie cutter model, like school to medicine or an undergrad, or what was your sort of way into it all?
Yeah, definitely not. I did. I loved science at school. My dad's a sort of engineer, and I've always loved science. I always thought I'd be a vet. And then when I sort of looked into it a bit further, I realised there's probably a bit of a ceiling with veterinary things. Only so much you can do, so much clients are willing to sort of, fund in terms of investigations. And I thought, I'm not sure. And also being quite empathetic with animals, I thought, I don't know if I'll handle this field. So I sort of steered away from that. I ended up going and doing a Bachelor of Science at uni in public health, and then went into the public service. I'm from Canberra, into the Department of Health for ACT Health, and worked in sexual health policy. And I thought, yep, this is where I'll put my love of science, but also my sort of enjoyment of maybe health governance. And I worked with the chief science officer, who was an infectious disease expert. And I realised quite quickly I really enjoyed the clinical aspects. Not that I was doing anything clinical, but the clinical aspects within the department far more than sort of the health governance stuff. And I thought, maybe I need to. And he said to me, you should apply for medicine. So I sort of applied for medicine. I started when I was 25. So I'd done my uni degree. I'd worked in the health department for a year, applied that year, and then got on and moved to WA for that. So I definitely wasn't that traditional. I never, I didn't grow up thinking I'd be a doctor, certainly. And I haven't really got any in my immediate family, any doctors actually.
Yeah, that's cool. I think like I'm pretty similar to that. Like I didn't know, it was only until like someone mentioned it, and then you're like, oh yeah, why not? We'll give it a shot, and then it sort of ends up working out that way, which is kind of cool. So then you got into med school, and then so you moved from from Canberra to WA to do it. That would have been like a massive shift and stuff, hey?
Yeah, yeah. I mean, it was good. I don't think I thought I'd ever stay in Canberra forever. Like Canberra's a great city to grow up in, but it's quiet and cold, obviously. So I was quite excited to move to Fremantle and do my uni there. And my brother was in Perth at the time, which was nice, but outside of that, I didn't really know anyone. So I did my 4 years there, and then I actually thought, because I did a year in Broome on a rural scholarship, and really enjoyed the infectious disease and Indigenous health. So I thought maybe that's where I'll end up. So I actually did my internship in Darwin from there. But that's when I did the orthopedics and the emergency and the rehab and sort of changed direction. But yeah, initially I thought maybe infectious disease would be my area.
Yeah, cool. Yeah, I've got a mate who's trying to sort of, angle onto to the ID pathway. It's certainly, yeah, very interesting and like, geographically will change what sort of stuff you see, more north, more tropical stuff, and it could be like, yeah, some super weird stuff that you could see, which would be awesome. But I think you've landed in the field that suits you. Hey, you're pretty happy with where you are.
I think so, yeah. And look, we still get some, like I enjoy a bit of general medicine. Certainly, obviously, I don't have the skill set I used to, but you get a lot of infectious disease in team environments, just minor stuff, but managing COVID, even post COVID, when there's a bit of heightened awareness of illness and infectious illness, that's been really interesting and sort of enjoyable to manage that in teams and work out ways, like particularly with the outdoor sports, you can get people training outside pretty safely, but then you limit their inside exposure to everyone else. So that's been really quite fun to navigate and look back onto those years when I sort of had a bit of an interest in that area.
For sure, for sure. Do you reckon you've seen like the injuries or like the types of conditions like change since you started? Like, is it maybe evolved differently, or is like sport being played like a little bit differently? And I don't know, you see like injuries change. I mean, obviously, like there's a massive push towards like head injuries and like concussion and all that sort of stuff. But yeah, I don't know. From your point of view, have you seen anything like major shifts?
Yeah, definitely. Like I think most of my experience is in footy, but certainly, we used to see a lot of soft tissues, heaps of hamstrings, heaps of calves. And then that sort of tailed off a little bit. So obviously, like the S&C guys, the sport and conditioning guys, and strength and conditioning, sorry, and the high performance managers really started to get to the perfect point where they were putting enough load into the players and enough strength to sort of mitigate those overuse injuries, the soft tissue injuries. And then we sort of started to see the opposite, where they were sort of trying to find this edge and really running these guys, to the point of like 40, 50 kilometre weeks. At training, and then we started to see a lot of stress fractures, so overuse again, but more in bone. And I guess as you know, it's not aesthetics as much, but they want these athletes to be lean, so they're good runners. So all of that sort of plays into these stresses where they're a bit relative energy deficient. So they're not fueling quite enough to what their output is required, and they start to get their bone health depleting. So we had a fair spate of that, definitely. And then certainly I think the trauma peaked for a little bit in footy as well, where the tackling became really contested and aggressive. And that was the sort of, particularly around the year that when I was with Melbourne in 2021, when we won our premiership, that was the real focus, was really like this contested tackling. And that was our strong point. But then we got a lot of collarbone fractures, a fair bit of concussion. There's sort of consequences to changing the way that the strategy works and the tactics work. And then certainly lately, obviously, concussions a huge focus. I'm not sure that we're getting more numbers, but probably we're getting potentially some more because of awareness, and people are diagnosing it, and players are being more honest about reporting it. So it's probably increasing in that respect. And obviously the public are well aware of it now as well.
Yeah, that's like super interesting to hear. And it's like I guess from, just like a viewer at home's point of view, you see, oh, someone had a knock, they're probably out for a couple of weeks, they do some concussion test, they're not allowed to play the rest of the match. Then it's like, well, those add up over time. You probably see, as you said, like these chronic people who come back, ex players or whatever, and they might tell like a different story. I'm not sure if you have much exposure with those ex players who are finished or
Yeah, we certainly run a program at the AFL for past players that have had issues with concussion. And obviously back then, There wasn't these tight guidelines. It wasn't seen highly negative, and I'm talking 20 years ago, as a negative thing. They were seen as tough if they got knocked out in a game and then came back on the field that same game, which, as we know now, is an absolute no-no in terms of brain recovery and tissue recovery. So certainly things have changed dramatically, and definitely for the better, thankfully, but it doesn't help those people in the past that obviously had multiple concussions and played on with concussion, unfortunately.
Do you reckon is there like a big difference between like the AFL guys and then AFLW in terms of like the injuries? I mean, same sport, but like obviously like male and female differences. You might see some sort of differences in the injuries.
Definitely. And firstly, like when it started in 2017, AFLW had huge rates of ACLs, and big concussion rates. And no doubt that was because they had a lot of cross coders. They had volleyballers, netballers, basketballers, soccer players coming into this sport. That's suddenly 360 contact, which is so different to either their non-contact sport or their limited contact sport. So they were the ones often getting these ACL injuries and concussion injuries. So there was huge disparity between the men and the women's in 2017. But actually, if you look at we were looking at the injury report for 2023, both of the seasons, it's actually almost come back down to very similar. So in terms of rates per 1,000 played hours, so definitely the technique's getting better, the coaching's getting better in AFLW. The girls have played it so many more years now. They've grown up playing it, so they've got the same skill set as the men in terms of head placement and awareness in the game. What is higher in the women's is definitely stress fractures in the feet and the lower limb. So that probably is a result of that relative energy deficiency in sport, where they're not often intentionally underfueling, but they're a little bit underfueled for their output. And that's often for the AFLW. It's tricky, right? Like they're part-time athletes. They're not like the men's. They're not training in the day. They're coming from their job. They're trying to quickly fuel, get some food in, straight to training, and then they're not eating dinner till 9 p.m. at night. So they're not logistically able to fuel effectively, and their training's getting more and more intense. So there's definitely those differences that are occurring. The ACL rate, concussion rate's nearly the same now. ACL rate's slightly higher, but it's not the 9-to-1 that it used to be. It's sort of come back down to the baseline population level between male and females.
Gotcha. Yeah, it sounds like they're trying to almost be like how you were as a junior doctor. Doing your full time job and then ripping off to training to do that session, and then you eat dinner at like 9:30, 10 o'clock at night. It's a crazy sort of like level of commitment.
It's hard. But I mean, at least they're paid well now to do that compared to, you guys doing it at state league level for the enjoyment of it, really. But yeah.
Yeah, 100%. Do you guys get like any medical students or anything like helping out at your clinic or getting, I don't know if they still do like work experience now or whatever, but I mean, apart from just these people who are interested in that area, like I feel like it'd be a good idea to place some of these students in these out of hospital fields because we only get exposed to like GP, I guess.
Yeah. I think it would be a great idea. We don't have routine. I actually, in saying that, there was, and I wonder if not so much in private clinics, but certainly in the hospital setting, there's some outpatient sports medicine clinics or rehab clinics. We got placed in those. So I think definitely some medical students are going to like private hospitals where they have these clinics, but not so much in the private clinic. But I agree. And, the future of sports medicine should also be in the public system. Like, we should be placed in outpatient clinics, offload the orthopedic department, because a lot of what they see is not surgical. It's this no man's land between GP and orthopedics, which is us. They need management of their chronic osteoarthritis, but it's not quite surgical yet, or they've had an MCL injury that's non-operative that just needs to be educated on their rehab. That's where I see our future. And then that way we can have more training spots. We can have medical students sitting in, residents working in those clinics and getting the experience to become registrars. And the other place for us, I think, is the ED departments in fast track for all the MSK on the weekend. That's sort of our bread and butter, and it's really enjoyable for us. There's a lot there that we could do that doesn't require sort of an emergency physician or registrar input.
Yeah, I feel like they'd take a massive load off the ED guys, the ortho guys, and even like maybe some of the plastics guys if it's something minor. I'm not too sure, but Yeah, I mean, yeah, on weekends, like you see all like the Saturdays, Sundays, like footy matches, other sports. That would be a huge load off the healthcare system if you guys could get put into that aspect.
And I think back to when I was an ED resident, and no doubt ACLs came in, and I'd do the standard X-ray, no fracture, see your physio or your GP on Monday. When what they really needed was an outpatient MRI in the public system, in the private system, and follow up with a sports doctor or a physio. You know that we could coordinate that. That would be just a far better system than the radiating the patient, waste of a public X-ray, and not really giving them much advice other than to rise.
Yeah, 100%. I guess looking back at like your journey through this whole like like obviously your initial doctor journey and then transitioning to like sports med. Like as a female, do you reckon there's like any major like barriers or anything that you came across? I mean, as you said, like the field's like changing, and of course, it's like you get a point for being female and applying to sports med, and it's like moving in the right direction slowly, but hopefully, moving faster. But was there any like major hurdles you had to like overcome or?
I think the most major is just inherent bias. There's just an assumption, and it's not conscious. It's a subconscious bias that you're not as competent as your male colleague to do a role, and that's happened to me. On occasions where it's been recommended that a less experienced male colleague fulfill a role instead of myself, and it's fine once you're in the environment you're working and people see you and you get that respect, and people understand you're absolutely competent and capable of doing roles. But if they don't know you, often the male will get picked because they're like in all medicine. It's often a leadership role, being a club doctor. You're sort of the head of that medical chain, and they often just have this unconscious bias. It needs to be a male, unfortunately. And I think because there is a lot of really well-known, respected female physicians in sports medicine, that's changing. And you are thought of sometimes first for roles. And obviously, it's very sport dependent. Working in netball, I would say it's probably too far skewed to the other end. They're always looking for female physios and female doctors. And in fact, having men is quite valuable to have, a differing of whether a physio is male and the female doctor or vice versa. I think that can be really helpful in an all female sport or male sport. But what I have found is once you're in there, so even in footy club, which, you'll be one of the admin person will be female, or this is my experience, the dietitian will be, and then that's it in the footy department and yourself. Once you're in there and you gain that respect, and then they see the value, because a lot of even young males, they'd actually prefer it can be a bit more vulnerable at times, sometimes around a female. So often it works quite well. Some things that they don't want to, talk about, there might be some really sensitive stuff, and then they might seek out, often you'll have another doctor usually that'll be a male, and they might seek out them. But definitely, I think once you're in there, that you gain that respect, it's quite, there's no issues. It's getting in the door that can often be the problem, I think, definitely.
Yeah, 100%. But if like once you earn that trust, that respect of that team, you're the go-to person for all those guys. But as you said, foot in the door is a tricky thing, hey?
It's tricky. And then there's the really minor stuff, which is trivial, but it wears you down. Like they don't have female uniforms. So you end up looking like a school child when you're like, I'm quite short, in really baggy, size small male stuff. You just you don't feel sometimes confident wearing that stuff. You don't look great. You look a bit ridiculous. You're trying to run on the field with your pants rolled up and your sleeves rolled up. So and I, with all, credit to Melbourne Football Club, they started to get female sizes in. So things that you can make change, but I would say never feel backward about being forward about that stuff, because it seems trivial, but it's not.
They add up all the time, and then it's like things that I wouldn't even think about is just like not even a consideration, and it's just like years and years of all this stuff that's just accumulated. I guess just to like wrap things up, like what would you say to like that person who might be listening who's sort of interested in sports med or is not like feeling like hospital medicine would be like where they see themselves in the future? What's your like piece of advice for that person who is considering like a career in sports medicine, and whether they're male, female, or whatever. Like, what's your advice to them?
I would say if you've got any inclination, immerse yourself, like get some experience, sit in with people, talk to registrars on the program, particularly ones that have just got on. So come to the annual conference. It's a student rate, or I think it's a junior doctor rate you can get in, and then just network and talk to people. And it's not about forcing yourself on people, it's just understanding what their day-to-day life is. And all of us will have a different schedule, and different commitments in sports med. So do that, understand what it's about. Certainly I did that, and that was a really eye-opener to this world that I realized would be really exceptional. I would strongly recommend it if you're someone that would enjoy working for yourself. So we're, predominantly contractors. You don't get salarized, you don't get benefits, maternity leave. You sort of work for yourself. But I love that because then I've got flexibility. If I want to take leave outside of my sporting commitments, if I want to take leave, I organise that and I do it, and I don't have to, apply for permission or make it only 4 weeks. I could have 3 months off. So there's huge benefits, and the variety is great, and it's choose your own adventure. But you need to be someone that's independent and able to manage that. No one's doing your roster for you. So you need to be able to deal with competing commitments, and there will be weeks that you're on your computer in the evening trying to catch up on other roles, or like a Diamonds tour is coming up in a few weeks, so you spend a lot of hours in the evening catching up on that, doing a bit of screening. So it can sort of come in waves like that, but as long as you're aware of that, it's definitely a role that is very rewarding like that. But I would just say make sure you know what you're getting into, do some coverage, make sure you're able to work in environments where you're not supported by nursing staff and more senior colleagues. Like if it's you on the side of the football field, and I've had compound, tib fib fractures, it's me, it's a physio, no ambulance on site, no nurses. You got to be ready and prepared to, reduce it, analgese them, get them, comfortable enough to wait for that ambulance at half an hour away. So there's a lot of pressure, and you're suddenly the ED consultant in that situation, managing people, but these people don't have medical skills. The physios are pretty good on the sports side, but they're not really, they're not doctors. So you're sort of really instructing them how to use that green whistle, how to draw up some saline to put your drip in. So you've got to be prepared. It's very different to hospital medicine, but if you're interested in it, get exposed, understand what it's about, and then, think about applying.
That's really cool. Well, Laura, thanks so much for jumping on this. This has been awesome to hear about the side of like sports medicine that I don't know, like I feel like this is the most I've ever learned about sports med. Like before this, I like have no idea like what it is other than snippets you see on TV or anecdotally from people. So it's been really cool to hear from you, to be honest.
Yeah, no problem. The annual conference this year is at the MCG in Melbourne. It's going to be great. It's combined with Sports Medicine Australia. So if you are thinking about it, it's in October. Jump online and have a look. It's a really great way to meet lots of sports doctors and sort of get immersed in it.
That's awesome. All right, I might buy a ticket. Who knows? All right, so that's the end of that conversation. If you want to be part of something like this, you think you have an interesting story in medicine to share, maybe it's how you got in, and maybe it's that you got on a different training program or you went through some adversity, if that's something that you think you'd be interested in doing, then send me a message. The link will be in the description, how you can get in touch. If you know someone else that's probably keen to share their story, or you think that they would be a great person to share on this, then definitely link them in and we can get them on. If you want to stick around, there's plenty of other videos on here to check out and keep you informed, keep you interested, and keep you learning more about medicine. So there you go. Otherwise, we'll see you next time. Bye.